Welcome all of you to the 38th live webinar on orthopedic principles with Dr. Mikhil Jain for a fellowship exam related lecture. Dr. Mikhil Jain recently completed his fellowship exam in trauma and orthopedics and also the FEBOT exam. He works in Wrexham, United Kingdom. Over to you, Dr. Mikhil.
Thank you, Dr. Gopalan. So, continuing from my previous lecture where I discussed some FRCS related hand and wrist topics, this time I will talk about the really hot topics which will be asked to you in some station or the other when you give your FRCS Orth exam. So these cases might be asked to you either in the short cases or in the adult path station or sometimes even in basic sciences. So the topics which I'm going to cover today are 3 topics on foot and ankle, and then if we have time, I can just talk quickly about 5 to 10 minutes about knee, some topics about knees as well. Okay, so starting with the common, I was asked this topic. In fact, all these 3 topics at different points of my exam, so I thought I'll cover these 3 topics. And tendo Achilles rupture was some topic that I was asked twice in my exam at 2 different points. Okay, so I'll tell you where exactly I was asked and how I was asked this question. So this a common scenario of an acute tendo Achilles rupture is in a man in his 30s and 40s who's not played sports for a long time and suddenly wants to suddenly gets back to playing sports without a lot of warm up and things like that. So this is a history of a 45-year-old man who was playing badminton after not having played for many years. Suddenly heard a pop when he was trying to hit the shuttle to the other side, and then after the injury he dropped down to the floor and couldn't continue. He came peculiarly to the clinic the following day complaining of having kicked in the calf. That was his main symptoms, having a feeling of being kicked in the calf and unable to push off. So this was a classic. I mean, the diagnosis of tendo Achilles rupture is not really difficult. So, but how you talk in the exam is very important. So I mean, everybody knows in the clinical setup how to diagnose an acute tendonitis, but the exam answer would be based on AAOS guidance, which came out in 2010. The diagnosis of acute Achilles tendon rupture is based on clinical examination with the history and any 2 of the 4 criteria. So these criteria are on squeezing the calf. If you don't elicit plantar flexion of the foot, that is a positive Thompson's test. Then you feel a palpable gap. There is increased dorsiflexion because the passive tension of the tendo Achilles is lost. And then there is a decreased ankle plantar flexion strength. If any 2 out of these 4 criteria are present, then based on AAOS guidance, this patient has sustained an acute tendo Achilles rupture. Mind you, sometimes on squeezing the calf, the plantar flexion might still be present. This is due to the action of plantaris and tibialis posterior. It might be worth, if you're thinking of scoring more, it might be worth mentioning about the Simmons triad, which consists of, as I mentioned, the calf squeeze, the angle of declination, and a palpable gap. So the angle of declination is basically when the patient is lying down in the prone position, the resting position of the foot is slight plantar flexion. However, in case of an acute tendo Achilles rupture, the foot lies in plantigrade to slight dorsiflexion as a passive tension is lost. So that this basically means the angle of declination is increased. Okay, so this is how you talk about evidence-based diagnosis of acute tendo Achilles rupture. Now, the next question inevitably that you would be asked is how do you manage this patient? So there is a lot of controversy as to if you manage this operatively, non-operatively, what is the re-rupture rate and things like that. So there is some guidance, there is some evidence, and I'll go through that with you right now. And if you mention this in the exam, you should be okay. So where I was asked this question was in basic sciences. So they took me in the different stages of tendon healing. So you have to mention about phases of inflammation, proliferation, remodeling. Then I was asked about to draw the microscopic structure of a tendon, and then as well as the constituents of a tendon in terms of what percentage of collagen 1, collagen 2, and things like that. So that was the first point that I was asked this. And again, I was asked this from the clinical perspective in the adult path station. So as I said, there are 2 ways of treating this surgically, 2 ways of treating this operatively and non-operatively. So the historical thinking was if you don't treat it operatively, then the risk of re-rupture is high. And the tendon heals with some shortening or even some lengthening, but you never get the right tendon length if you treat it non-operatively. Okay. Then if you're going to treat it operatively, which are the candidates which are needed, which are suitable for operative management, and which ones do well with non-operative management? What kind of, whether it's an open surgery that you perform or percutaneous surgery that you perform. So we'll go through that now. Now, before going to the surgical bit, what are the advantages of treating this non-operatively? So you avoid the big scar, you avoid injury to the nerve, you avoid risk of infection, you avoid a wound breakdown, and risk of infection can be catastrophic in that region. And it is, of course, less expensive. And even after you treat the patient surgically, you have to put them in a functional orthosis to let the tendon heal and the wound and the soft tissues to settle down. Okay. But the traditional thinking of treating this conservatively was in a plaster with plaster kept in full equinus, but that is an absolute no-no. So if you mention that it will be difficult for you to recover that. So the treatment non-operatively would be in a functional brace or by a smart rehabilitation functional protocol, and we'll go through that now. In terms of imaging, so what is the role of imaging in tendon Achilles ruptures? People talk about ultrasound. So ultrasound should be performed when you're not sure whether it's a complete rupture, whether it's a partial rupture. Mind you, there's nothing like a partial rupture. Yeah, it's either ruptured or not ruptured. If it's a partial rupture, the treatment inevitably is, as in if only some fibers are torn, then patients do not have as much pain and difficulty, and they usually manage very well, and the tendon heals very well. Now, the dynamic ultrasound is performed to see the tendon opposition in complete plantar flexion. In complete plantar flexion, if the gap between the two ends of the torn tendons is greater than 1 centimeter, then these are the patients who might benefit from surgery. Now, the functional rehabilitation or the smart rehabilitation protocol, which came out from the group in Swansea, mentioned about use the phases of tendon healing to let the tendon heal non-operatively. So the key components of these are immediate weight bearing mobilization. Okay. Early weight bearing mobilization, but limit the range of movement. Yeah, do not allow them complete dorsiflexion because that might impair the tendon healing. Now, in terms of there have been loads and loads of papers which have come out, which have been published showing the operative as well as non-operative treatment of tendon Achilles. There was a recent meta-analysis which showed that the re-rupture rate is slightly higher in non-operative group of 3.9% compared to 2.3% in the operative group. However, the complication as expected of infection, wound breakdown is higher in the operative group compared to the non-operative group. So this is something that you need to be thinking about. And if you use a functional protocol or the immediate weight bearing in the vacupated boot and changing the angle of plantar flexion weekly, then that is a safe way of treating it without increasing the re-rupture rate. Now, this is an example of rehabilitation. So as soon as the patient comes to you with an acute tendon Achilles injury and you've decided to treat this non-operatively, then you give them a vacupated boot immediately after the injury. You keep the vacupated boot, you keep it in 30 degrees of equinus for 3 weeks and allow weight bearing as tolerated with the help of the vacupated boot. After every week, from week 4 onwards, you reduce 5 degrees of plantar flexion and gradually bring it to plantigrade position. At about 10 weeks stage, you can wean the boot and start some exercises as guided by the physios in terms of resistance bands to body weight and so on and so forth, and then slowly build on from there. Now, what is the worst that can happen if you treat it non-operatively? It might take a long time for it to rehab. The calf strength or the push-off strength might be weak, and the tendon Achilles can re-rupture. If it does re-rupture, we always have the option of doing an operation later in the form of an FHL transfer. So that is something that needs to be explained to the patient. So it's very important to know what the protocol in your department is. Now, most hospitals in the UK have this treatment with the vacupated boot, which is functional orthosis. You start with that non-operatively, and if the patient still has persistent symptoms at about 10 to 12 weeks, and and you can get an ultrasound scan at about 10 to 12 weeks to see if there is any healing. If there is no healing and the patient has weakened push-off strength, then you can always perform an operation later. the indication for operation is in really select group of patients in whom they are high functioning professional football players or rugby players, in whom the rehabilitation, they need to be back on the pitch much quicker than normal population. Okay, so these are the patients that you would think of an operation. Otherwise, the treatment is largely non-operative for tendon Achilles rupture, and you would be safe to say that in the exam. There is a UK STAR trial which has been which is going on. We're talking about the operative and the non-operative management of it is basically comparing the operative and the non-operative management of tendon Achilles, and the results will be coming out soon. Second case, this is again something I was asked. This is a 73-year-old lady who's retired, fairly normal BMI. I mean, just above normal, 27. She likes walking, but her walking is now restricted to less than a mile. She's otherwise fit and well. Now, as you can see, the ankle exercise suggestive of frank arthritis, but the overall alignment is neutral with no excessive varus or valgus. So this is a tricky case where what is the treatment option, whether it's ankle fusion or ankle replacement. Nothing is, both the options are correct, both the answers are correct. You just have to justify which one you're going to choose and talk about the evidence for that. So as I said, how do you assess these patients with ankle arthritis? So you look at the duration of symptoms, look at how it's affecting their quality of life and how their walking distance is affected. Then you have to look at their systemic conditions. If they have diabetes mellitus, if they have peripheral vascular disease, if they have chronic venous changes around the skin, if they have a very high BMI, if they are smokers or non-smokers. So those are the things which will have an impact on the operative management, and these are the things that you need to keep in mind. Of course, any treatment, you can't just straight out jump onto the operation. You have to talk about non-operative management. So the standard line for non-operative management for any arthritis, whether it's hip, knee, or ankle arthritis, would be simple. I'll just come to that. Yeah. So activity modification, weight reduction, or BMI reduction, patient education. Sometimes you can use injections in the form of steroids, and bracing might help. So this is what you have to, and analgesia as per the WHO pain ladder. So this is a standard thing which you can mention for any arthritic patient anywhere in the body. Once these non-operative measures have failed, then you have to think about a surgical treatment options, which can be either for this ankle arthritis. There are only two really: ankle arthrodesis or total ankle replacement. And ankle arthrodesis can be done by two techniques: open technique and a arthroscopic technique. Ankle fusion is still the gold standard for ankle arthritis, and if this is something that you're used to, then you're very safe in saying this. And we can talk about what happens, what are the advantages of ankle fusion over ankle replacement, and what are the disadvantages. So what is good about a fusion? So the ankle fusion is a very predictable conventional surgery which has been performed for ankle arthritis for the many years. Only over the last 10-15 years, ankle replacement has become more and more popular due to the change in the implant design and so on and so forth. But still, the complications are quite high, and there is a big learning curve for ankle replacements. So as I said, ankle fusion, because it is a conventional surgery, it is technically straightforward. It is less expensive. Most people use only 2 cross screws. Sometimes you can use a plate across the tibia and the talus, but most people are used to using 2 screws. Minimally invasive technique in the form of an arthroscopic preparation of the joint even reduces the risk of wound breakdown and all of that, those kind of things. Because it is minimally invasive in the form of arthroscopic fusion, which can be done for neutral alignment. Usually, it can be done in high BMI, diabetics, patients whose skin condition is not very good, those kind of things. Ankle fusion can also be done in young patients, because once the ankle fuses in a young patient, then they don't need any further surgery for the rest of their life. Now, obviously, there are disadvantages of an ankle fusion. You lose the range of motion of the ankle, which means your gait is affected, and some patients might not be happy with a stiff ankle. And if the ankle joint is quite stiff and fused, then it increases the stress on the adjacent joints like the subtalar and the talonavicular joints, and they have a risk of developing arthritis in the future. So these are the points that you have to talk about when you explain to the patient as to what they need to expect after the operation, such as an ankle fusion. Now, the evidence is quite clear in favor of arthroscopic fusion. There is a 94% fusion rate if you use arthroscopic preparation of the joint compared to open preparation. This is because of rapid activation of the bone healing cascade. The soft tissue envelope is intact, and the recovery period is much shorter. So all this is so most people are now performing arthroscopic ankle fusion unless the deformity is which you have to correct is quite large, in which case arthroscopic ankle preparation is difficult. When I say deformity is greater than 15 degrees of varus or valgus on either side is 10 degrees of deformity on either side is difficult to prep arthroscopically, in which case you have to consider an open ankle fusion. But the method of fixation remains the same. You can use either 2 cross screws or 2 medial lateral screws, either or. Now, ankle replacement is a good option in select group of patients. You have to know which are those patients, which I will talk about very shortly. But what is the benefit of an ankle replacement? It preserves the range of motion in the adjacent joints. Sorry, it preserves the range of motion in the ankle joint, thereby reduces the stress on the adjacent joints and prevents arthritis. The function is slightly better. In the gait is not affected as much. Walking on uneven surfaces is not as difficult. But obviously, as I said, because this is a fairly recent operation and not many people are doing it, it is more challenging, it is riskier for the patient, and it may need a revision. Sometimes the dissatisfaction rate is quite high. So patients quite often have a medial gutter pain and things like that, in which case you might have to consider a revision. Revision of an ankle replacement can be performed to a revision ankle replacement, or it can be even revise it to a fusion. But then it obviously gets more and more difficult. In terms of ankle replacement, the first, I mean, the commonly performed ankle replacement was the star ankle replacement from, I think, Sweden. And in the developer series, the results were greater than 90% survivorship at about 12 years. However, in the experts, they were about 85% in about 8 years. And the results, if you go down to up to 10 years, is about 71% survivorship. So it's not as good, but the techniques and the learning curve and the implants are getting better and better. And with highly cross-linked polyethylene that is used as a bearing surface, sometimes you can use as a fixed device, a fixed bearing or a mobile bearing, and the results are getting better now. The commonest one that is used is the Infinity ankle replacement, which has very good results. Now, the patients who usually benefit from a total ankle replacement are the patients with normal BMI, with neutral alignment of the ankle, no major comorbidities, low demand patients, like so elderly patients who have not as much demand. The typical patients who benefit from ankle replacements are patients with rheumatoid arthritis who have significant arthritis in the other joints as well, and you can't fuse each and every joint. So if you're thinking of fusing the subtalar and the talonavicular and the calcaneocuboid joint, then it's better to perform an ankle replacement in these patients with rheumatoid arthritis, as they have all arthritis of all these 4 joints. Obviously, you have to understand the risks and explain to them about the risk of revision and the dissatisfaction and the medial gutter pain and so on and so forth that I've already mentioned. Now, a patient who's less than 50 years definitely doesn't get a total ankle replacement, because the lifetime risk of getting of having a revision is very, very, very high, as well as the revision results are not very good. Arthritis secondary to neuromuscular disease, ankle range of motion, which is very restricted anyway pre-operatively. You're not going to achieve a lot post-operatively by doing ankle replacement. If there is no arthritis in the adjacent joints, then you can think of fusing the ankle joint, rather than doing a total ankle replacement. Instability of the ankle due to lateral sided instability, in which case there is a high risk of loosening of the total ankle replacement. As I said, if the deformity is greater than 15 degrees, it's a contraindication for total ankle replacement. And in patients with significant medical comorbidities like diabetes, which is poorly controlled, peripheral vascular disease, so on and so forth. So as I said, fusion is still the gold standard. Total ankle replacement has potential, but you have to monitor the results. If you're giving the exam in UK, you can talk about the NGI results. You have to consent the patients appropriately about the risk of developing arthritis in the adjacent joints if you're doing a fusion, and about the risk of revision if you're doing a total ankle replacement, and so on and so forth. There is a trial going on in UK called the TARVA trial, which is comparison of total ankle replacement versus ankle arthrodesis for patients of ankle arthritis. The results haven't come out yet, but it would be useful to mention this in the exam once the results have come out, and mention briefly about the results of this study. Now, talking about Lisfranc is again quite a common question that is asked in the trauma viva. So a classic patient would be a 46-year-old woman who slipped down coming down the staircase. She's otherwise fit and well, but has got a high BMI, and there's a lot of axial force going through a plantar flexed foot that usually causes a midfoot injury. Now, this patient is, they usually present to accident and emergency where they are x-rayed, given a below elbow back slab and sent to fracture clinic. These patients usually have a very swollen foot and they are unable to weight bear, and that should raise suspicion. So something which is very important or pathognomonic following an injury like this is a plantar ecchymosis, which should raise your alarm bells for Lisfranc's fracture injuries. Now, we've already covered this. For any foot and ankle case, it is very, very important to ask for diabetes, smoking, peripheral vascular disease, and the occupation of the patient. Yeah. And then we'll talk about the imaging which is needed for Lisfranc's disease. So plain radiographs initially are non-weight bearing, but they might hide the injury. So you should aim to get weight bearing views or the stress views, which can show subtle Lisfranc injuries. The obvious ones will be picked up on X-rays, which are non-weight bearing anyway. CT scan is to see the extent of the injury, and MRI scan sometimes can be done in the acute stage to see the ligamentous injury. Like this is for purely ligamentous Lisfranc's injuries. So Lisfranc basically is a wide variety of diseases, wide variety of injury, wherein there is a dissociation of the midfoot from the hindfoot, and uh, it, and there's no one particular treatment which fits all. You have to treat the injury based on what you have in front of you. So the base there is no single procedure which is superior to the others. So sometimes the undisplaced one in low demand patients can be treated non-operatively, but you have to have a very low threshold to convert them to an operation if there is instability, persistent pain, so on and so forth. The other options obviously are open reduction, internal fixation, or or you can do a primary arthrodesis. We can talk about all of that now. So there was a trial there is a trial which is in fact running in Finland, where they are comparing non-operative versus primary arthrodesis versus primary ORIF for patients with Lisfranc's injury. And the next thing to, as I said, in terms of management, the minimally displaced or the stable injuries, which in low demand patients can be treated with just a plaster for about 6 weeks of non-weight bearing. In terms of surgery, because they present with so much swelling and ecchymosis, it's worth waiting for the first 1 or 2 weeks for the swelling to settle down, for the soft tissue to settle down, before you think of doing a fixation or of fusing the joint. In terms, it is very important to maintain the mobility in the lateral columns. So it is important to, even if there is an injury to the lateral column, it's better to fix it with just K wires so that you've not made them rigid, because if they become rigid, then it's difficult for patients to walk on uneven surfaces. So you just need to do what needs to be done for that particular patient in front of you. Now, who are the patients who are usually treated with fixation? So minimal comminution, limited joint involvement, yeah. So or the younger patients. Now you can fix. You have a wide variety of options to fix it. You can fix it with screws going across the joints, or nowadays what is common is the bridging plates. And you normally don't tend to remove the bridging plates unless there is any issue of irritation over the dorsal surface. K wires, as I said, are used for the column 4th and column 5th, or basically 4th and 5th MTPJ, as it is best to preserve mobility there. Now, who gets a fusion? The purely ligamentous type of injuries usually do well with fusion. Significant comminution, where you are not able to reconstruct all the Chopard joints correctly, and older patients and patients who present with patients who come in with delayed presentation. So these are the patients in whom the primary fusion might be a decent option. As I said, it is sometimes a subtle Lisfranc can be missed. So you have to correlate the mechanism of injury and get further imaging like a CT scan or a stress view. The role of stress view is decreasing more and more, and with the with the easy availability of CT scan, you can obviously get the CT scan done sooner rather than later. So as I said, in summary, so the three conditions that we talked about today: tendon Achilles rupture. So conservative treatment with functional rehabilitation protocol. You can mention about the SMART functional rehabilitation protocol, which was published by the guys in Swansea. They offer equivalent functional outcome compared to surgical treatment once the tendon heals. The risk of re-rupture is slightly higher with the functional rehabilitation protocol compared to surgery. However, the risk of complication is much lower with non-operative management compared to surgery. For treatment of ankle arthritis, arthroscopic ankle fusion is still the gold standard, but total ankle replacement is emerging as a viable alternative in a selected group of patients. And this is because of improvement in the learning curve of the surgeons. The technique, the instruments are getting better, and we are getting better with our patient selection as well. For Lisfranc's injury, have a very low threshold to perform a CT scan to diagnose the injury in case of several Lisfranc's injuries, and there is no one particular treatment. So you have to treat the patient depending on the injuries that that patient has, as it is a spectrum of injuries. Thank you. So these are the 3 topics that I've covered today in foot and ankle. If we have some time now, we can discuss 5 to 10 minutes of knees, but I'll ask Dr. Gopalan if he's okay with that.
Yeah, I think Mikhil, we'll have a knee session on a different date.
Yeah, that's okay. Yeah.
And because these are quite core topics for the foot and ankle, and I think that's, you have covered a lot, because we can address a few questions that have come up.
Okay.
See, someone is really concerned about saying arthroscopic ankle fusion as the gold standard, because is it really the gold standard?
Yeah, so I would answer this question. So if once, so okay, let's answer it from the FRCS perspective. Yeah, I've discussed the X-rays, I've discussed the assessment of the patient. Now the next question that the examiner would ask you would be, okay, doctor, how would you treat this patient? I would treat this patient by non-operative management in the first instance in the form of analgesia as per the WHO pain ladder, intra-articular steroid injections to have both diagnostic and therapeutic benefit, bracing, patient education, weight reduction, and activity modification. Once these non-operative measures have failed, then I would think about offering the patient surgical management. In terms of surgery, I would the gold standard for management would be an ankle fusion, as this is a time-tested conventional way of treating these patients. Now, at this point, the examiner might ask you, okay, doctor, what are the benefits of doing an ankle fusion? Then you can talk about all the benefits that I've mentioned. Then the next question would be, how would you do this patient? So then you can talk about the recent advances and the recent papers. The one paper published by Chandrappa in 2015 has shown a higher union rate with arthroscopic ankle fusion compared to open ankle fusion. So based on those studies, because the rate of union is about 94% with arthroscopic fusion compared to open fusion. So if you just talk about evidence, there's nothing like, you can easily say ankle fusion is the gold standard, but you can even defend it by saying, you can even say ankle, I would want to do an ankle replacement, but you have to give your answer. So there's nothing, as I said, it's gold standard. It means this is the time tested conventional way. How you do it is up to you, and you have to just defend what you say.
Okay. And ankle, someone wants to know more about the ankle replacement, because there are so many designs, like
Correct.
So many designs. So which is the one that has the best survivorship?
Yeah, so the one that has the best survivorship now is, I mean, if you have a look at the ankle, the National Joint Registry, the Infinity ankle has a very good survivorship. It has come in the, I mean, it has been in the market only for 5 years, and the results are about 85%. So it has a, it has an uncemented tibial component, an uncemented talar component, and a polyethylene in between.
Okay.
Yeah, so that is the one that is but in the exam you have to it never goes up to a stage where you have to mention about the brand names and things like that. You have to talk about the generations of ankle replacements. So the generations are currently we are in the 3rd and the 4th generations. So initially they used to be single component, as in a single component. Then they decided in then they had, I think, all poly talar component and things like that. But the one that is there in the market is uncemented tibial, uncemented talar, and a polyethylene in between. So that is the one that is currently going on.
Currently the most accepted one, right?
Yeah.
And
but if your exam reaches that stage where they ask you about the different types of ankle replacements, you're basically doing very well.
okay, so that's good. And
yeah,
someone wants to know about the Lisfranc method. I mean, what is the best accepted method for fixation of a Lisfranc for the exam purpose?
For exam purpose, so you have to basically treat the X-rays. The concept of treatment, you have to have a column concept of treatment. Yeah, the first column is the first metatarsal, which so what is important is there is no intermetatarsal ligament between the first and the second. Yeah, so the first column consists of the first metatarsal and the medial cuneiform and the navicular. The second column consists of the second and the third metatarsal with the middle and the intermediate cuneiform. and the third column consists of the fourth. And so you have to have a column concept of fixation. So if you mention about a column concept of fixation where you fix the first and the second column rigidly, and the fifth component, the first and the second column rigidly, and the third column, which basically consists of the fourth and the fifth rays, you have to keep them mobile. But it might be a case of Lisfranc where there is no injury to the fourth and the fifth metatarsals at all, and the injury is only restricted to the basically the Lisfranc ligament, which runs on the plantar aspect of the medial cuneiform. If the injury is only there and there's a flake, then you just have to fix those fragments. So as I said, there is no one particular treatment. You have to talk about fixation or fusion or non-operative, but in terms of fixation, you have to fix what is there in front of you rather than a blanket treatment for everything. And in terms of fixing, you can fix it with either cross screws or you can fix it with bridging plates. Bridging plates are now more and more common because those are locking plates and they achieve more, they give more stability.
I think some kind of V plate, VA plate or something. Is it very common there?
Yeah. So these plates, there are edge plates, there are VA plates, there are different forms of plates, and as I said, you have a lot of different options of the plates as well. So you can choose which one, like what is the injury in front of you, and you can have a look and fix it accordingly. That is not really important. How you have a lot of options of fixing these. AccuMed produces a lot. I mean, but that is going in the details of things.
Okay. And I think for the tendo Achilles, the triad that you said that was really good, the Simmons triad. So would you mind explaining it to them? I mean,
so the Simmons triad. So there's always a confusion between Simmons test, Thompson's test. So the best thing to do in the exam is mention the test. So squeezing the calf elicits plantar flexion in normal population. So Simmons triad has three components. It has the calf squeeze test. So once you squeeze the calf in normal population or the contralateral uninjured leg, you get plantar flexion. But in patients with acute tendo Achilles injury, when you squeeze the calf, you don't elicit plantar flexion as much as what you do on the other side. Sometimes you might still see a bit, but that is due to plantaris and tibialis posterior. The other component is a palpable gap. Okay, so if you run your fingers down the back of the tendo Achilles and compare it with the normal side is intact all the way down up to the calcaneum. But in cases of an acute tendo Achilles ruptures, you see a sudden gap at just before the insertion onto the calcaneum, or sometimes higher up, depending on where the injury is. The injury can be at any point from the commonest injuries at the musculotendinous junction. And the third component is an angle of declination. So when you lie down in the prone position, you can have a look when you lie down in your bed, tonight. The ankle is in a slight plantar flexed position due to the passive tension of the tendo Achilles. But in patients with a tendo Achilles injury, the ankle, the resting position of the ankle is either neutral, or it sometimes even goes into slight dorsiflexion because the tension of the tendo Achilles is lost, and that is called the angle of declination. So the angle of declination is decreased.
Okay. Mikhil, you know what, in the more recent editions of our popular textbook, Campbell, you would have seen there's a sign called as Mattels test. So basically, that's exactly the angle of declination. So is that a common question there? I mean, the Mattels test?
I mean, they don't really ask the question. I mean, they can just ask you, okay, how are you going to diagnose? So rather than just enumerating the points, this is how I would do it. If you talk about guidance, AAOS guidance or the Simmons triad, so the examiners like to have like to know of a structure, or like to know that you've thought of when you're answering the question. So you might not. I'm not aware of this Mattels test, but
it's the same as the angle of declination.
Declination. Oh, okay. So yeah, you can describe rather than going into details. Sometimes you can just mention, describe the tests. That's enough. There are ways of answering this question. This is how I prepare my answers. I have a structure to every answer. So then, examiners like that way of thinking rather than just randomly blurting out points. Oh, there's a palpable gap. Good. There is bruising. There is this. There is that. There is that. Rather than that, you have
a systematic way.
Correct. Yeah, a structural, systematic way for answering every question, and that's enough. Usually for the exam.
Okay, Mikhil. I think there are no more questions, and we can end the session. Thank you once again, Mikhil, for joining us. Your previous lecture was well accepted by all the FRCS trainees. I could receive a lot of messages from the guys in the UK that they're very happy with your first lecture, and I'm sure this would be the same and have the same level of impact as the first one. Thank you once again for joining us. We'll end the meeting.
No problem. Thank you.